My name is Ankit Patel. For those of you that don't know me, I've been practicing in the UK for the last 5 years, I would like to say. Been qualified for almost 10, and that does sound really old. Let's begin. So I'll be conducting a routine examination in detail. If you're wondering what's with the photo, the guy on the left is my cousin. That's a lie, he's not. He's just a famous actor that I got a click with at Heathrow Airport. Anyway, right, so what's the most important thing when it comes to routine examinations? So it's very important that we know why they're here. So sometimes someone comes in and we don't know what the obvious reasons are, even if it's right in front of you, like we can see here. So what's the number one thing that we need to know? We need to know the chief complaint. What's the reason for why they're here and obviously not sitting at home? What are your symptoms? How long they've been going on for? When was your last eye test, etc. And of course, you know, sometimes you will get some patients that are just there to waste your time, and there's nothing that you can do about that. Now, if you're wondering why have I written out these people's names, Albert Einstein, Nelson Mandela, Mahatma Gandhi, and of course, fortunately, Donald Trump, what do they have in common? Well, it's really important because we all need to do this every single day in a routine examination. And that is history. Thank God Donald Trump is part of history. So very important because it will give you a baseline to all your diagnosis, right? For example, if you're looking for a patient that suffers from hypertension, you would obviously, you know, look for corneal ulcers and stuff. Of course you wouldn't, but you would look for some retinal changes, which is very important. Are they on any forms of medications? Medications always can play a part with the eye. For those of you that know, you've got chloroquine, hydrochloroquine that can take retinal toxicity. So you would be looking around for that. Allergies, do people suffer from allergies? During these times, it is very important that you ask about latex allergy, because I'm assuming all of you during these appointments are wearing some form of protection like gloves. So asking is never going to hurt. Now, family history, very important, and I know most of you probably do ask this. Obviously, if someone's over the age of 30, has family history of glaucoma, you would want to know more about their eye. Now, I know by books, those of you that read Kansky, it always says from 40 plus, glaucoma can start beginning to take a trade, but that's not always seen in practice. You may see a 32-year-old who has high intraocular pressures, there's cupping, there may not necessarily be a visual field loss, but there may be some death to the ganglion cells. So you may pick that up on an OCT scan. So does that mean because books say glaucoma doesn't start from 40, would you then not refer? No, you would still refer. And it's always important to refer because somebody else may tell them that they're going to just, you know, they're going to monitor them, but you need to do your job correctly. And that's what's important. Now, so types of routine examination, of course, the first and foremost is visual acuity. And you can check visual acuity with their current specs or without their current specs. I be honest, I normally do it without. And that obviously depends on how short-sighted they are, how long-sighted they are. Cover test, don't really do it on everyone because you have to remember the whole point of doing a detailed routine examination is to understand when and where you need to do these tests, to understand a better diagnosis. So technically, when I do them, I do it with the patient specs on. However, if someone complains of headaches, especially during computer work, which is what most people do these days, I will do a cover test without. So the reason why I would do it without, it's just to rule out a small deviation at near, so a fixation disparity. Now, I'm sure the following that you can probably see on my screen where it says, I hate prisms, I actually do. I don't think there's a single human being who has done optometry that loves prisms. And it's only because they are complicated. But if you do get your hands on them, you will learn to use them better. If a patient of yours walks into your clinic, complains about headaches or eye pain, especially the term shooting eye pain. Now, of course, the shooting eye pain can occur due to severe dry eyes or even moderate dry eyes. But just to rule out retrobulbar neuritis, please do an ocular motility. And for those of you that don't know what ocular motility is, it's just checking out the muscular movements binocularly. Right, so examinations. If those of you have an autorefractor, then that's great, quick and easy. Of course, it's easy if it's a good autorefractor and it works well. Now, NCT, a non-contact tonometer, is one of my favorites because it helps me diagnose a lot of things. For example, your pressures. Now, when you do have an autorefractor, or even if you have a keratometer, do use them. So always look for the K readings so that you can distinguish and understand astigmatism. So if you're wondering, why do you need to understand astigmatism in a routine examination? Well, you have two types of astigmatism that you're going to see routinely, and one's lenticular astigmatism, and the second is a corneal astigmatism. Now, to differentiate whether someone has lenticular, you just need to see their K readings. So if someone has a -1 seal that comes up on your autos, and on the K readings it shows -1, then you know it's total full corneal astigmatism. However, if on the K readings you find a -050, but on your refraction there's a -1, then there is a hidden -050 lying around somewhere, and that would be in the lens. Now, does that really make a difference to your refraction? No, it doesn't, but it actually does make you feel like you know what you're doing. Sometimes it makes me feel that way. Now, intraocular pressure, I'm sure every country has their different guidelines. I am someone that starts doing intraocular pressure based on symptoms. In fact, I'm a type of clinician that will do intraocular pressures on children who suffer from bad headaches, for example, only because intraocular pressure can show a connection to a raised intracranial pressure. For those of you that don't know what that is, an intracranial pressure is, of course, the pressures that reside in your head. Now, in the circumstances, if a 15-year-old boy walks into your clinic, complains of severe headaches, you don't really find much swelling behind the eye. It's not much harm in blowing a few puffs of air into their eye. So at least this way, you have done everything that you can. Now, pachymetry. This is a technique that is normally on most NCTs, but in the circumstances, if you don't have it, don't worry about it because it's not at all essential. I'm just a little bit extra and therefore I do it. So the reason why I do it, it's because I, of course, and just like all of you, you're going to get patients that are going to ask you about laser surgery. And they ask you, some people tell me it's not good, some people say it's good. What's your views on it? So what I tend to do is I'll do a few gross examinations. Now, pachymetry, 2 reasons. If your corneal thickness is low, then obviously, you know, you can consult the patient saying, I kind of predict that you may not be fit for it. Going back to the intraocular pressure, what do you do for a patient who's, let's say, 35? Pressures are 26, 27, 24 in one eye. Do you then just refer them because it's gone above the guideline? Don't make that mistake. And the reason why you shouldn't make that mistake, it's because their corneas could be very thick. Sometimes what tends to happen, if you've got pachymetry, it's a good reason for you to rule out a referral. So I do get a lot of patients who have a thick cornea, and a non-contact tonometer is not going to help giving you a defined pressure test. But of course, if you're using contact tonometry and the pressures are still 24, 25, corneal thickness is high, you need to refer them. Just don't even wait around, okay? Now, slit lamp ophthalmoscopy. This has to be my favorite examination for the entire day. So always start off by looking at the adnexia, which is your lids, then move on to the conjunctiva, sclera, cornea, iris and pupils, the way you would normally do with your anterior segments. I use a 90 diopter Volk lens. A lot of people use the 70, a suprafield. I use the 90D because I get to see a bit extra and it's not as magnified. Obviously, it's more magnification. What I tend to do is start at the optic disc, because so if I'm looking at a patient's right eye, I always get them to look at my left ear. Sorry, I pointed to my wrong ear. I'm sure some of you figured that out, but I'll get them to look at the opposite ear, and I start at their optic disc. I then follow my pathway around the central retinal vein, going towards the branches. Do all 9 gazes if you possibly can, so up, down, left, right, as you can see over there, only because there's possibilities that you might see some thinning, some white without pressure, with pressure, with patients who are severely myopic. It's very important to look out for these things because in your daytime clinic, you may not get access to various machineries. You may not have an OCT, and I certainly don't have an OCT in my practice. So the slit lamp and the ophthalmoscope is probably the best thing that I have to potentially suspect and diagnose future conditions. So it's very important that you get up to date on how you're practicing with these lenses. I don't tend to write down in a graph as soon as I'm practicing my Volk lens. I remember it as much as I possibly can. Now, I know some of you probably feel as if, there are conditions out there in the retina, and you're not too sure what they are. Now, let me just tell you something. In my time of practicing, all because I've been practicing for so many years, it doesn't make me a better optometrist than everyone that's in this room right now. In fact, I may not be even as good as you guys. But what's important is not diagnosing. It's important that you know it is not normal, okay? Because there's always going to be someone out there that can diagnose the condition. But these patients are coming to you first. They're not going to the ophthalmologist. They're coming to you, the optometrist. You need to know that there is an abnormality that you have just seen. You can tell your patient that, look, I'm a little suspicious, I'm curious, I can't diagnose this correctly because there needs to be further investigations. I mean, you can blab on with whatever you like to say to them to make them feel better and comfortable, and just say, but I'm going to refer you to a specialist that would know where the problem stands. Now, it's best to do something than not to do something. So always keep that in mind, okay? Contact lenses, yeah. Not my favorite, but it's, of course, a very, very good visual aid. Now, of course, contact lens is not something that normally comes up in a routine examination. It's a whole separate appointment. Most people these days in this generation normally wear a daily lens, but I still get patients that wear a monthly lens. In fact, for those of you that don't know what an Accurate Oasis 2 weekly is, it's of course a bi-weekly lens. And I have patients that use one lens for the entire month. So they'll come in and they'll tell me, look, nothing's gone wrong. Of course, it's just a disaster waiting to happen. I can't tell them what to do really, but I tell them it's wrong. So why is it that I would do a stain for a person that's wearing a monthly contact lens? Well, if someone's working on the computers, their blink rate's low, they're possibly going to have some dry eyes. But what if their dry eyes is not because of using computers? What if it's actually because they've been using an extended lens for the entire month? So you stain them, you invert the lid, and you may look around for some papillae. You might find some staining on the cornea that you may not be able to see without using a fluorescein stain. Look, it's never going to harm you. It takes me approximately 20 seconds to instill it, and then a further 25, 30 seconds to have a look at the eye. Yeah, they probably leave with a bit of orange eye running around the cheeks, but I really don't care how they appear. So always be mindful, always try and do as much as you possibly can. Of course, as you are aware, when people suffer from dry eyes, they can potentially lead from frontal and temporal headaches and a mild amount of eye pain. So finish it off in style, do your refraction. It is not important, and let me just remind you all, it is not important for you to start conducting your routine examinations the same way I do. But if you did, then that would be great because you're following in my footsteps. Do not follow my footsteps. Now, use your refractive techniques. If you have an autorefractometer, use that. If you have a retinoscope, then you can use that. What I tend to do is start off with a duochrome test. Of course, that's your red and green. For those of you that don't know what a duochrome test is, it's red and green, and it has letters in there. Okay, so you can definitely find it in your Acuity charts. Jackson cross seals, the best tool, but it's annoying when they keep telling you the wrong answers. But yes, it is the best tool because you can refine your axis and power. Flippers, for those of you that don't know what a flipper is, it has a plus and a minus lens. There's probably 4 lenses on each block, and you can use it for your fogging techniques when you're using binocular testing. When you can, of course. As you can read that, I'm sure you can understand that not everyone does it. I do get slightly bored of it and my legs hurt because I'm quite short. Next, let's go to our next. So visual fields, the most important. So why did I leave this to last? I do not do a visual fields on all my patients. And I'll tell you why. When you're my patient, I spend most of my time talking to you and boring you. Some of you may understand what that feels like right now. So visual fields is obviously a test that you need to make sure they've got their full concentration, okay? And if they're tired, you're going to get wrong results. And I hate it when they don't do it correctly and I have to repeat the test. It's just the most annoying thing. So always make sure that you ask them the right questions. How do you feel to conduct this test? It's going to take 2-3 minutes per eye. Are you tired? We can reschedule, and it's okay to do that. But I don't do it with everyone. So when do I normally do it? So I will do it based on a patient's complaints, okay? Their age, their symptoms, family history like glaucoma. That's where the importance comes about. So if someone complains of headaches, is it important that you do the visual fields? Some of you may disagree with my following statement, but the answer to that is no. It is not always important to do a visual fields because someone complains with headaches. And why is that? So the reason to that is you may have already diagnosed the reason to their headaches with your earlier examinations. So if someone comes in and they have no glasses, no previous eye test records, and they've been complaining of headaches, you find a -2 seal for the first time, well, that explains why you're getting a headache. Now, are you going to then take up more time of that patient who's probably had that eye strain and strain their eyes even more on a visual field machines? Maybe not, but it won't make any harm for you to ask them to conduct it, whether they want to go for it. You see, someone like me, on most days, I'm more busier than her. So you got to understand, I don't get much time, okay? So do it when you need to. If you're not too sure, always do it, okay? There's no harm in always doing it. If you're quick, great. If you're running behind, reschedule them. You're the optometrist. No one's ever going to say to you, this person is taking up too much of our clinic time. And if they are, you're the optometrist. And always remember that amount, respect yourself, okay? Please, please, I know that you have a lot of clinics, a lot of hospitals, a lot of opticians. These are your patients. Your duty is not always to supply them with glasses. Your duty is only to relieve them from their symptoms, improve their health and improve their life. They're only coming in because there's a problem. They're not, well, some come to waste your time, and I totally understand that. But if someone walks in and they've got a problem, they're struggling with their day-to-day life, their work, they're sad, they're in pain, then give them a service where they leave happy, okay? And most importantly, comfortable. So if you're all wondering how hard I work every day, well, I work very hard, okay? I see up to 16 patients a day, and I work 6 to 7 days a week, and I've been doing this for many years. So who do I work as hard as? This guy here, okay? That should answer your question on how hard I work. So it's been a pleasure, everyone. Thank you. I hope you've enjoyed this conversation with me. And if you guys do have any questions, please feel free to fire away, okay? And I'm going to hand you guys back over.